Next, we're going to hear about the Oregon Health Plan, and the program will be presented by Mark Gibson and Vicki Gates.
Thank you, Mr. Chairman. It's a pleasure to be here. The Oregon Health Plan represents a process which combined public education and outreach, clear public values, articulation of clear public values as they relate to health care, and a technical evaluation of health care services, which formed a set of priorities which were then integrated into our legislative decision-making. Was it innovative? We believe it was. It changed our health care eligibility debate from one based on categorical distinctions, which sometimes treated siblings in the same family differently or required a woman to become pregnant before receiving health care, to one based solely on family income. It changed our service level debate from one based on the relative political power of various interest groups to one which focused on health and on providing the care which improved health to the greatest extent possible. And it changed our reimbursement debate from a budget-driven discussion which arbitrarily paid providers at below cost and resulted in barriers to access for our Medicaid clients to one in which providers are paid fairly but also have a contractual obligation to provide quality care to our Medicaid clients.
How would we judge our progress? Over 150,000 additional people have health care coverage because of expanded Medicaid and private incentives and reforms. Many have not seen a doctor or a dentist for many years. Medicaid clients have a new benefit package which integrates mental health, chemical dependency, and dental services into our health priorities and our delivery system. An independent commission able to evaluate and weigh health benefits played a key role in producing what is a significant expansion of benefits for old as well as new participants. An effective partnership with our private sector has built a capitated managed care delivery system which serves 85% of our Medicaid clients and has increased satisfaction with access to care with quality and health status. Preventive services have increased, building, we hope, a future dividend. The system is more accountable. For example, individual plan performance on our client satisfaction survey has been made public. Costs are more predictable. Hospital emergency room use and uncompensated care have dropped, a benefit that's been recognized and supported by our business community. Unexpected benefits include 8,000 families who could qualify for welfare but choose health benefits and a job instead. The people of Oregon support the plan. We've built a coalition by putting people at the table, which has proven to be long-lasting and we hope adaptable to change. Millions of Americans lack health care coverage, and in many areas this problem is growing. Our progress toward a solution has relied on engaging the broad community in the discussion and the debate necessary to create a plan which makes sense to the people of our state. Evidence of this is a community coalition which recently used our initiative process to put a tobacco tax increase on the rolls to expand the Oregon Health Plan.
Could the plan be replicated? We believe it could. But to focus on replicating only our end product misses an important part of the story. More than anything, the Oregon Health Plan represents an effective process for public decision-making. This process has several critical elements which could be replicated in many different subjects and jurisdictions. It utilized an extensive public outreach process which both educated Oregonians and elicited from them a clear statement of the values that they wanted their health care system to support. It then used this broad-based feedback from the public to shape a technical evaluation of the services available in the healthcare system to provide an explicit ranking of healthcare services based on what Oregonians said they wanted. It also used the best actuarial science available to determine realistic costs for providing each of the services on our priority list. Finally, it required our legislature to use these values, this clinical expertise, and this costing methodology in its process for allocating resources. Implicit methods of changing levels of care, that is, under reimbursing providers or treating equally needy persons differently, were no longer acceptable. The legislature was held explicitly accountable for every service provided or not provided and the consequences of those decisions. The soul of the Oregon Health Plan is not just the destination we've reached, but the journey we took to get there. It was a process that combined the efforts of the most distant communities in the state with those of the state's highest decision makers. It utilized thousands of volunteer hours of service to craft a solution to one of our state's most vexing problems, and in the process developed a public commitment that to this day serves as a foundation which will allow us to reach our ultimate goal of assuring access to a reasonable package of health care benefits to all Oregonians. Thank you.
Questions from the committee? Yes.
The plan started, in the late 1980s, 88, 89, thereabout, and of course got a lot of national attention. Why haven't other states ventured forth, in your judgment?
I think one of the reasons other states haven't tried to do exactly what we have done is that it took us approximately 5 years to reach implementation. The healthcare prioritization process was a very diverse and involved, both technically and socially involved process. And in addition to that, obtaining the federal waivers that were required to bring this kind of a concept in under the Medicaid program took another good long time. So we actually only began to implement the program in early 1994. It's when we opened the gates and began to bring in the new eligibles under the Medicaid program. I would say that some of the, there are some indications that interest is growing again now that we've actually been able to get this on the ground and running. And so I think that those are the reasons it hasn't happened earlier than this.
Antonio.
A follow-up to that question, and that is, now that you really have gotten the program going, what will it take to truly expand medical coverage to all of the residents of Oregon? Because from my reading, it's still very limited.
We think that what it's probably going to take is a two-pronged attack. If you take a look at who really doesn't have health insurance in this country, there are two problems. There are people who look as if they're making choices, and there are people who are economically shut out of the system. We think that probably a little over half are people economically shut out of the system given the cost of health care, and that means creating some new public-private partnerships, some new resources, which of course the tobacco tax is something that we've got some hope for, who can create a partnership with people using their resources, hopefully employer resources, and public resources. The question of people who make choices, I think, is a more difficult one because, in fact, they affect all of the rest of the system. There are other places where we've been more willing to make decisions about choices that people make in terms of car insurance, whether or not we require workers' compensation insurance. And the other thing, of course, that we've done to take a closer look at that one is we really have tried to remove all the market barriers. Our last legislature, even before the federal legislation, tried to create a piece of insurance reform legislation that would mean if you had resources, the market would be open to you, individual business, small business, large business.
Two pending questions, the first from Jack and the second from Lynn.
I'd like to ask about partisan politics. How come there aren't any?
I think it says a lot about the process that was used. Essentially, the process was so inclusive that and the solutions that were reached through this process addressed the legitimate needs of the parties that came to solving the process, and so that really began to tear down the political barriers. They had to find solutions to their legitimate needs within the context of what we were trying to accomplish, and once they were able to do that, we reached the objective we were trying to reach in terms of significantly expanding the Medicaid program and reforming the market, and the political objections just weren't there. It's hard to make a partisan issue out of something that such a broad base of folks support.
Well, in that case, what advice do you have for people who live in Washington, D.C.?
To start with, well, I will just say to start with everyone to get folks to the table. Don't craft something outside of the interests that are going to have to be a part of making this thing work, bring people to the table, articulate a set of principles that can guide the discussion that people can agree to, and then move from that platform forward and resolve their legitimate interests as defined by the principles you agree upon, and I think a solution's available.
The next question from Lynn.
There was a brief mention that the increase in costs had been paid for by, whoops, okay.
Oh, that's all right. Ask the question, we'll get the answer.
I'm so obedient, you can tell it's trained by nuns. It's time over, I'm done.
That's the first time I've seen her obedient, but
That's what
Go
the
ahead,
nuns
Lynn.
used to say, too. There was a brief mention that the cost increases by expanding the Medicaid services had been paid for by an increased tax on tobacco product, whatever. Without talking to that, what over the last 5 years or per year have been the increased costs that have been picked up by state funding, whatever that funding mechanism was?
It's more difficult now to really track what the increment is because we've essentially changed the total program. We started out with an increment that was roughly $200 million. As we compare the old and the new program, there's such a difference in the cost dynamics that it gets harder with each year that we go out to actually be able to do that because we have had such a massive conversion to managed care, and our figures still show us that there's a significant difference between those few clients that we have left in fee-for-service and the clients who are part of our capitated system. The majority, however, of funds that were used to support this increment were Oregon general funds. The tobacco tax was a small piece of what it took us to get the original
Go
program
back to the
into
first
work.
part. So you have no data on the cost increase from year 1 through year 5?
Well, we are tracking it in terms of cost estimates that we made based on the old system vis-a-vis the new system. But those were estimates based on assumptions in regard to how costs would grow and how a system
How
would
do they
develop.
appropriate if you can't tell them how much it costs?
Well, they appropriate for the program as a whole. It is now our old Medicaid program, our new Medicaid program are now one program.